Welcome to This Explainer. Today, we're unraveling a truly high-stakes medical mystery from case reports in cardiology. We're talking a massive mass inside a patient's heart, a rapidly ticking clock, and a literal plot twist right on the operating table. If you've ever wondered how modern imaging meshes with old-fashioned patient history, well, you're in for a really fascinating ride.
It's basically a perfect storm. We're going to see how a patient's past medical history and their current hidden habits collided to create a terrifying clinical scenario. It was a situation that almost led a team of top-tier doctors to perform a completely unnecessary open-heart surgery.
Section 1. A medical mystery begins.
So let's dive into exactly how our patient first presented, because the clues were super confusing right out of the gate. Picture this. You're the ER physician. A guy in his 50s rolls in absolute agony. He's got sudden, persistent left flank pain, nausea, and he's vomiting. You run the initial blood work, and his high-sensitivity cardiac troponin, which is a key marker of heart damage, is skyrocketing at over 300 picograms per milliliter. Normal is under 20. Your immediate thought? Massive heart attack, right?
Well, the clues just didn't line up. Despite the immense cardiac stress those troponin levels were screaming about, his initial EKG showed absolutely no acute ischemic changes. His coronary arteries were not blocked in the typical way you'd expect during a myocardial infarction. So this huge disconnect prompted the doctors to dig much deeper with advanced imaging.
And that's when they made a terrifying double discovery. An abdominal CT scan revealed a massive infarction, basically tissue death, in his left kidney. And at the exact same time, an echo discovered this massive, highly mobile 2.5 by 2.0 centimeter mass just lurking right inside his heart's left ventricle. Plus, his heart was weak, pumping at an ejection fraction of only 30%. The mass was actually breaking apart, sending debris downstream, which is what was causing that severe kidney pain.
Section 2. The two prime suspects.
With this deadly, mobile mass actively throwing off pieces, the team had to act incredibly fast. They were looking at two very different, very dangerous prime suspects. Suspect number 1, cancer. The patient had a significant history of malignant melanoma on his right shoulder just 10 months prior. Even though it was treated, cancer metastasis to the heart was a grim but real possibility. Suspect number 2 was a massive blood clot, or organized thrombus. Because of his low ejection fraction, blood could literally just be pooling and clotting in the heart. But without a biopsy, they couldn't be 100% sure which one was threatening his life.
And the clock was ticking loud. Pieces of this mass were actively embolizing, traveling through his bloodstream and destroying organs. So a huge multidisciplinary team of cardiology, oncology, intensive care, and cardiothoracic surgery convened. They made the rapid decision that they just couldn't wait. They prepped him for emergent open-heart surgery, specifically a thoracotomy, to physically cut the mass out of his left ventricle before it caused a fatal stroke.
Section 3. The pre-op plot twist.
Okay, so the patient is wheeled into the OR. The surgical team is scrubbed in. But right as the scalpel was about to hit the skin, a routine procedural check completely flipped the script. They did a pre-op transesophageal echo right there in the operating room to get a perfect look at the heart before making the first incision. And guess what? The enormous mass they saw just a day prior had suddenly and significantly shrunk on its own. It was a fraction of its original size, leaving just a layered remnant on the papillary muscles.
Solid cancer tumors just don't melt away overnight. This miraculous shrinkage, which was helped by the IV heparin blood thinners he got at admission, proved unequivocally that this was an organizing blood clot, not metastatic melanoma. The surgeon instantly halted the surgery. A massive, invasive, and incredibly risky procedure was totally avoided in the nick of time.
Section 4. The cocaine connection. So the immediate threat of surgery was gone, but the mystery wasn't over. With cancer officially ruled out, doctors had to figure out what caused this huge clot in a patient whose coronary arteries were actually patent, not blocked. This led them straight to the patient's history. He had an active polysubstance use disorder. He was on a methadone program, but crucially, he admitted to using cocaine just days prior to ending up in the ER. And cocaine is a notorious trigger for severe cardiovascular calamities. It doesn't just spike your heart rate, it fundamentally attacks the architecture and function of the heart muscle itself. Section 5. The domino effect.
Let's look at the science and see how this builds into the perfect storm for a massive heart clot. It's a fascinating but terrifying cascade of biological events. Chronic cocaine use bombards the heart with catecholamines, like adrenaline and noradrenaline. This persistent overstimulation inhibits nitric oxide, making your blood vessels constrict and damaging the inner lining of the heart, what we call endothelial dysfunction. Over time, it literally causes heart muscle cells to die off.
The result? Non-ischemic cardiomyopathy. The heart gets weak, floppy, and just can't pump efficiently. On top of that, cocaine makes your blood super sticky by increasing platelet aggregation and fibrinogen levels. All of this creates a textbook case of Virchow's triad, the unholy trinity of blood clots. Cocaine hit all three markers in this guy. 1. Blood stasis, because his weakened heart couldn't pump blood out effectively. 2. Tissue damage to the ventricular wall from chronic drug toxicity. And 3. Hypercoagulability, meaning the cocaine chemically forced his blood to clot abnormally. Basically, his left ventricle became a factory for this massive thrombus.
That toxic recipe resulted in a really horrific phenomenon known as an embolic shower. The clot in his heart was super fragile, so pieces just kept breaking free. On day 1, a chunk traveled to his left kidney, causing that initial flank pain. But it didn't stop there. On day 4 of his admission, he developed sudden, severe pain in both legs, and his right foot became cold and pale. Another scan showed fragments of the heart clot had traveled all the way down and blocked the arteries in his right leg and left knee.
Section 6. The final diagnosis.
This patient was essentially a ticking time bomb of blood clots. But luckily, because the true nature of the mass was discovered via that imaging in the OR just in time, the team could pivot away from surgery and toward the exact right medical treatment. They successfully transitioned him from IV heparin to an oral blood thinner, apixaban, for at least 6 months to dissolve the remaining clot and prevent new ones. He was started on guideline-directed medical therapy to strengthen his heart muscle and, crucially, provided with intensive counseling for his substance use disorder. The best news? Extensive follow-up scans months later confirmed what the shrinking clot suggested. He remained 100% cancer-free.
It leaves us with this final, powerful thought. Yes, the high-tech imaging in the OR absolutely saved this man from a dangerous and unnecessary open-heart surgery. But it was his honest medical history, admitting to recent cocaine use, that ultimately unlocked the mystery of why this deadly biological cascade happened in the first place. In an age of billion-dollar medical tech, is a simple, truthful conversation between doctor and patient still the most life-saving tool we possess? Think about that next time you go in for a checkup. Thanks for joining me on this explainer, and keep asking the right questions.